Hello everybody. Happy New Year. With new energy, I would like to welcome you our Vascular Ultrasound Master Class. We're going to continue our monthly Vascular Ultrasound Master Class, but I definitely would like to have a big thank you for all the people who came to our annual Vascular Ultrasound Master Class. Can I have my first slide? So the slide shows that we had 3,200 people watching us live, and I would like to thank you everybody, and I would like to propose some new dates. Please let us know if there's any issue with those dates. It will be November 12 for the Vascular Ultrasound Master Class, and there was a demand of a separate TCD carotid because again one day we wouldn't able to cover everything, so we propose a TCD Master Class with carotid on June 10th. If you have any questions during these cases, please on the laptop just type in pollev.com and enter DeBakey. That's on your laptop or computer. You can submit your questions without your name, or if you have a phone, just text DeBakey to the number 37607. I have 5 interesting cases. We are going to start with the easy one. And with this easy one, we just want to show you and refresh our interpretation, which is again, these are the velocity values, how we are interpreting our carotid ultrasound studies. Basically, the 50% stenosis needs to have at least 125 peak systolic velocity, at least 40 end-diastolic velocity, and a ratio over 2. So when we reach the 70% stenosis, we are jumping to 230 and diastolic 100, or the ratio of 4. So those are the 2 numbers I want you guys to kind of remember, recall. Those are the 2 ranges, and we'll try to fit everything in. The other interesting reminder about the diagnostic criteria, when we applied for accreditation, our accreditation body, the IAC, told us these 2 accepted values. So if we have more than 50% ECA stenosis, the peak systolic should be more than 150, or for the subclavian, the peak systolic velocity should be over 200. And again, we are not talking about fistulas or anything. These are just a native subclavian peak systolic velocity. My first case is a 59-year-old female with a history of hypertension and a recent TIA, and we scanned her as an outpatient. Our first step is, again, you see a cross-section, common carotid artery. You see the thyroid, you see the IJ. After the grayscale cross-section, we put a color box on, and we are confirming the CCA, and all the way up to the ICA, the bifurcation is patent, and you have a flow in the carotid system. And these are the longitudinal pictures now. We have a still image when we measure velocities. Here's the proximal CCA is 98/27 on the left-hand side of the screen. You can see those. Mid CCA 93/28. And I noticed some snowing in the waveform. I want you guys to pay attention to what are those white spots. We rarely see snow in Texas, so this is why I hate to say, but that is something that we don't see every day in our carotid system. And here's a view with the clip of the IC and the ECA, minimal plaque. And again, you see minimal plaque in a bulb. Velocity, again, do not indicate any CCA stenosis. ECA is 74/11. And again, you see more snowing, these bright spots in the waveforms. The bulb with a normal velocity again. This is a mid ICA, 69/36. And I think this is the picture I inserted into my report, because I think when your waveform gain was a little bit lower, you see this white snowing a little bit better, especially in this distal ICA. And this is our clip when we're comparing the flow direction of the vertebral to the common. Again, another way you see the vertebral vein and the arteries opposite direction. That's one more confirmation. I see a low resistance antegrade flow in the vertebral artery. Again, my scale is showing me that the head is here, signal going away is red, and that's the flow direction towards the head, and the blue is the vein. We have one more picture for the subclavian, and the subclavian is under 200 triphasic waveform. On the other side, starting again with the cross-section grayscale, common carotid artery, minimal plaque in the bulb with the color, patency confirmed. Longitudinal views of the common carotid proximal 77 23, mid 63/17. Excuse me. And I want you to notice that there's a snowing is stopped. So we're waiting for the winter to come, and unfortunately I see no more snowing. So again, the waveform, almost like East Texas had a snow, West Texas did not have a snow, and with a minimal plaque in the bulb. Velocity is normal range. Proximal ICA is 102/40. Distal ICA 81/40. Here's the vertebral again, same direction with the carotid, same color box, so we did not flip the color box. And the vertebral flow is a nice low resistance. And the subclavian is again under 200. Actually, nicely, you can see the vertebral origin right there. And it's a triphasic waveform. So what I want you to see the time, so it's a 9:20. On the same day, the patient had an echo done at 8:40, and this was the echo contrast showing, and I think the timestamp is 8:45. So it's interesting that 30 minutes later, when we started to scan the left side, all the emboli were gone, but again the contrast agent was present while we were scanning the right side. So I just want you to everybody aware of, when you see these, don't give heparin right away and don't yell for embolization. First, just check, make sure the patient did not have an echo done with the contrast agent, because this is how the contrast is going to show up. And again, just few slides about the consensus. So since 95, we have a consensus about this microembolus signal, and what I think it's important that this microembolus signal needs to travel in the waveform. So because it's traveling a centimeter per second speed, you see it in the systole or you see it in the diastole, that's traveling slower for sure. It's a short duration, a unidirectional spectral signature. So if it's sitting on a zero line, that is not moving. So if it's sitting on a zero line, the sound is deeper and it's just a thump. These are like a little higher pitch, crispy sound when you see these emboli going. With the snowing, you would expect to hear a little bit of blah, blah, blah. But in this case, again, we just couldn't have a sound recording done. When we are injecting, again, this is how it looks like on the TCD, that these are the different signatures are variable, so you have a totally different brightness of all these micro signal because they're different size. When we're doing a bubble study and we are injecting saline, these are uniform particles. So this is why I want you to see, pay attention that if there's a bubble coming from a saline or any injection, they are more like uniform microembolus signals you're going to see in the spectrum. Also pay attention that if they are on the bad side and the nurse injecting something into the IV, you're able to pick up some venous embolization. You see is a non-pulsatile flow pattern, and in that non-pulsatile flow pattern you probably wouldn't see any flow, but that is not arterial. Those are all probably coming from the IJ. And thanks to COVID, we started to pay attention to this tiny microembol signal on the venous studies. So again, in this case, we did not see any major clot. It's just a tiny microembol signal telling me that proximal from this measurement, there's a source which is giving me that microembol signal. And again, the other place where we see clots, and we never pay attention when we see this brightness because it's just a single snowflake. This is a pseudoaneurysm in the groin. And what you see here, this is one single microembol signal. So this is a tiny particle, because the signal is again generated from a red blood cell. So something else traveling between those cells is giving us the signature. The size could be anywhere from 10 micron to 100, 200. Okay. My second case will be a little bit more challenging, so please fasten your seatbelt. And a 61-year-old female with bilateral carotid stenosis history, with the past medical history significant with previous subarachnoid hemorrhage, hydrocephalus with shunt, basal aneurysm stenting, and we have a stent in the coronaries with a CABG surgery. The first, again, we're starting with our cross-section. Cross-section sees already a little bit of plaque in the common carotid, but definitely plaque in the bulb. And definitely we see color flow, at least some part of the common carotid, but I have flow in the EC and ICA. So my common carotid is open with a low resistance flow. So that's, interestingly enough, I'm seeing a low resistance flow pattern with lots of diastolic flow. I'm still seeing that flow. And I have a flow all the way up to the bulb. So this is my right distal CCA. I see lots of plaque in the bulb area. My velocity is still low, but I'm searching for, in that bulb area, first with a grayscale, but after that with a color, with this aliasing kind of pinpointing a stenosis, which is 204/60. So by those range, we're still under the 70% range. So this is definitely more than 50%. What I think you also need to notice that the systolic upstroke is also delayed. So if I go back to the common carotid artery, that was another key element that always you see a gorgeous systolic upstroke here. And if you, first thing you notice after the bulb, and especially if you have this more than 50% stenosis, that the systolic upstroke is definitely more delayed. And the other interesting, this shape of waveform that is kind of a little bit unorganized, trying to organize it behind the stenosis. Too bad I cannot play you the sound of it, but it's kind of interesting and a little bit more blunted distal blood flow with 146. Interestingly, the velocity did not decrease. So that is one clue for us that it keeps up the volume flow in that distal CCA area. I'm looking at the distal ICA, make sure that I'm not missing any pairs or any FMD in that region. ECA velocity is normal, under 50%. I just captured one more ECA velocity because of the aliasing, I guess. And my subclavian is definitely abnormal. I think the shape of the waveform is also, you can see this is a biphasic with a delayed systolic upstroke here. And again, the value is over 200. The direction of the vertebral is still antegrade. So same direction. Now you notice that we flipped it to the other angle direction. So because the vessel is coming from deep to the surface, my rhombus is angled to the opposite direction. But this is how you still see the low resistance vertebral waveform in there. One of our interesting method we trying to differentiate between two bilateral carotid stenosis is that we measure the flow volume. So based on the flow volume, we stole it from our AVF protocol. When a fistula is very important to have a flow volume done. And throughout the cases today, just remember these different flow volumes. So we call everything normal between 350 and 800, but probably up to 600. And this flow volume, we measure in the diameter of the CC and the mean flow velocity, giving us the flow volume 525 cc per minute. On the other side, I see a cross section, a little bit of lymph node in that bulb area. I don't see too much color filling. I see a little bit of in the ICA, but after the bulb, I do not see right there in the CCA. There's not much color filling. There's something noticeable in the lumen. Wall is thickened. Proximal, extremely high resistance. Excuse me. So the high resistance CCA waveform always give me bi-directional. So in this moment, you probably captured it when it's red. If you would freeze the screen, you can capture it when it's blue. So it's interesting that IJ is also going to the same direction. Very cool. So in that moment, you can call it even a reflex, but again, in a common, you can clearly see there's something filling up the lumen. And this extremely high resistance waveform indicating that downstream distal you may have an obstruction. You don't have any diastolic flow, and that telling me compared to the previous images from the other side, that's in my brain non-stop. I'm comparing what I saw on the other side. It's kind of reminding me, and definitely this is like a minimal just to and fro flow signal in the distal CCA, hitting the wall and bouncing back, hitting the wall. Sometimes we just call it a wall motion artifact when you see just this thump. Maybe it's not much of the flow signal. You see flow signal a little bit higher up, but maybe this is just a wall motion artifact on that. Throughout the, we turn a power Doppler on. Try to see if this is open or not. You try to see a tiny channel, right? Sometimes you see it right there, but it's maybe just vasovasorum, so not really convincing. What is convincing is this gorgeous video. So this is a gorgeous video of indicating that if you have a common carotid artery occlusion, your signal coming towards you, supposed to be your ECA, and that signal is feeding your ICA. So the blue signal is coming towards you, and then the ICA is going that way. And we will confirm it with a few velocity measurement, but I think that is easy. What's surprising that you need to probably tap on this one, that it's extremely low resistance, but this is because it's feeding the ICA, so the ECA almost like internalized fully. And I want you to remember this waveform because the ICA would be even less pulsatile for sure. Again, increased velocity in that ECA, and again, that ECA is most likely going to receive flow from the opposite thyroid superior branch and through from the ECA, or also some vertebral branches, and these are the branches probably coming in this area. And after the bulb, we're switching direction, and this is now my ICA. And the ICA, you need to notice the scale is dropped because now we are really picking up minimal flow going towards the head. So through that 300 centimeter per second peak systole, you're really measuring like less than 20. So that's the 20 centimeter per second peak systole is going towards the head now. And remember how much more positivity we had in the ECA. Here, it's really hard to tell if this is, again, systole starts here, or maybe you have a little bit of bump and systole starts here, and then like you have a steal similar to what you see in the subclavian. but definitely this is a delayed systolic upstroke. This part was started on the definitely on the blunted side, but low resistance. So I think the low resistance pattern, what I think is really important to giving us a clue that this IC is still open. My subclavian without stenosis, and a vertebral trying to sample in a common area when it was still red, and my vertebral is still red, so still going towards the head. And my velocity is low resistance, so again I'm just checking the vertebral, make sure it's not hypoplastic, especially in this case I'm gonna need my vertebral. May not provide too much collateral, because the 50/16, this is not I would expect higher velocity in the vertebral if this would provide collaterals from the posterior circulation with the PCOM, again with this total left CCA distal obstruction. And again, it's impossible to measure the flow volume on that spot. What I think was really impressive, and why I wanted to show you my last summary, that each of the velocities were done with a 60-degree angle. So here's 156. This is quite incredible, but this is, again, if you follow the protocol and you don't change the insonation angle for your measurement, that's just beautiful. So congratulations, and the summary is again just showing that we do have a 50 to 69% right ICA stenosis. We have a retrograde ECA, which is feeding my ICA with a total left CCA occlusion. And I may miss that one, why there was a right ICA stenosis. I need to go back, look at my numbers. I don't see my subclavian, but I guess we just would need to go back really fast. So before we started the cross section, one of the last image I was so focused on the flow volume, but I do not see a subclavian. Oh, here's a subclavian, yes. The 209 with the delayed upstroke. Yes, I think we definitely have more than 50% right subclavian stenosis as well. So right now I just would like to show you this video clip one more time, because I think it's really one of the beauty, and hopefully you don't see this too often, but get ready if you have a distal disease. In this case was a total occlusion of the common carotid artery. The ECA able to retrieve collaterals and able to feed your ICA in antegrade fashion still towards the brain. Okay, I would like to take a break really fast. If I have any questions. Maybe everybody's still on vacation and I do not see any questions. So we just keep going until I see any questions. So I would like to switch to the other computer now. Thank you. And if you would like to ask questions, just go to the pollev.com website, type in DeBakey, or just on your phone, you can just type DeBakey to the phone number 37607, and you can ask questions from us, or just email us if you're afraid to, have your question on the live stream event. We're happy to get back to you with the email as well. So my next case, it's quite interesting. It's an 81-year-old gentleman. And again, we know about a known carotid disease, and medical history with hypertension, coronary artery disease, and a former smoker. And we know that what you see and is diagnostic already on the first image, that is definitely new finding, and 8 years ago wasn't there. So it's really interesting that this whole obstruction, everything, maybe just really fun to look up any previous studies and compare to them and try to see where did the change really occurred. But definitely you see the cross section and you have the common carotid artery just filled up. And just this shows the whole occlusion. And interestingly, the little bit of color kind of give you a flow in a proximal, but where did the color go? Or maybe that's the flow is enough to supply the vasa vasorum on the wall with these occluded vessels, so make sure the walls still remain intact and something needs to supply the wall. So this is where the vasa vasorum flow come in, but we're just not sensitive enough to pick up with the 29 filter. So when we go after these occlusions, I think we need to decrease my color box and also drop my color scale. We dropped it to 20. You can see 29 goes down to 20. That's kind of cool. Someone was just reading my mind throughout the clip. And you see the color, definitely not feeling the common, but also after the ball, when you see the bifurcation here, there's not much flow going up to the ICA either. Interesting pulsation on the common, and these are the holes. And again, with the density, when I first saw it, I think the video and the presentation make it extremely bright, but when I saw it and what I see it on my ultrasound screen, is almost sold me as a acute occlusion, because there were some areas which was extremely dark, so this area for example, and I thought that this is like just not a cavitation but kind of option for recanalization maybe with the fresh. And the second thing why I was wanted to call it acute occlusion, and then I saw that we saw it in the previous few years, that's because the wall did not collapse. So when you look at the size of these vessel in a chronic obstruction, I expected a little bit more like less diameter for this vessel. Okay, and we are changing with the chroma, so try to see it if we can see anything better with this silver lining. Flow is again in the proximal CC is present. You see it with that cavitation, is even get some flow in these circles here. I don't see too much going that way. I guess we need to move the color box for that to see. Again, signal extremely high resistance, almost like to and fro. But it has not an occlusion, because almost like in the proximal end, it goes all the way in diastole. So when I see occlusion signal, it just hits the wall and bounces back, hits the wall. This is almost like a steel, goes up to the front and comes back. So almost like that Galveston Bay or whatever happened on the weekend, that all the water disappeared from the bay. This is what it is, that in diastole is still draining out all the blood flow what went up in systole. And again, here's your aortic valve closure. So not much flow in a common, and it's interesting that again the scale is dropped further to 18. Sample is increased, trying to pick up any sample, any tiny flow in that common carotid area, trying to see why this obstruction is definitely like a total occlusion, or you have a little of chance of recanalization. And by here, looking at this amount of clot, is definitely the diameter still there. That is calcified, so that is definitely where the old plaque buildup really started. Again, on the grayscale, now you can see the history. The gentleman really collected these for a few years. And here's a surprising flow. So after the occlusion from the ECA, you have a flow towards the head. Cool. So there was no flow or not much what we were able to pick up on the cross section, but here something from the bulb comes in, and I'm also suspicious that again these ECA collaterals from the thyroid superior branches from the opposite side we're going to give you that flow. So the only confirmation, I would expect to see a little bit of higher velocity on the ECA. And that's the first flow we see. surprisingly is high resistance, so it doesn't give us too much flow to the brain. I expect it will become low resistance, and then we can talk about some collaterals that where the ECA will give you this flow to the brain. And most frequently, if this would be a low resistance flow, that would be feeding your ophthalmic, and through the ophthalmic you can get that flow to inside the head. So definitely you don't see too much flow in the ICA and the ICA without any color signal, and nothing in the ICA. And one more time, we tried, and here's the vertebral going towards the head. Hard to compare to that common this time. So I guess we give up on that one, but it's a low resistance vertebral artery going towards the head. This is again a high resistance subclavian without the stenosis. Left side. On the left side, I'm seeing the common carotid, and I see some old plaque, calcified plaque, definitely disease. By color, I see patency, but I have some aliasing in the bulb. So with the 25, that aliasing is definitely give me some clue that that's going to be higher than what we anticipated. I expected way much more velocity on the left side. If you're right, common is occluded, I thought that the left side going to pick up all that flow and help out the brain. This flow is only 80 to 12. Common carotid has a plaque. Velocity did not increase, so the common carotid would be double velocity before we call 50% stenosis here. So velocity did not double, 103 over 23. I'm going to distal 9411, and again kept high resistance pattern, and ECA is increased. So definitely that we have to call it stenosis, but I hope that this is just one of the collateral pathways that we can see the diastolic flow hopefully carry over some flow to the other side, and that's what the ECA was feeding, the opposite ECA, and giving those collaterals. ICA 152 over 36. So this becomes really interesting because again it did not go all the way to 40. But because out of the 3, the ratio probably over 2, they're going to indicate that this is a 50 to 69. So one of the velocity went up to 57 in diastole, and the ratios just remain on 1.6. So let's see the next one. So again, now you have some other velocity that definitely also the systole and diastole indicating a more than 50% stenosis. So based on these two values, this is a 50 to 69 percent left proximal ICA stenosis. Mid ICA 106 27, and one more distal. The interesting waveform 79 26, a little bit unorganized, coming up probably with some tortuosity. Vertebral goes towards the head, will confirm it with the same direction with the carotid. Here's the vertebral waveform, and here's my subclavian waveform, and this is under 200. So again, just a interpretation. Right common carotid and IC occlusion. Right EC is antegrade, and we have a 50 to 69% left ICA stenosis. The ECA I will call collateral flow instead of stenosis in the left ECA, and less than 50% on both subclavian. So I am really anxious to see some questions because I'm kind of drying out to talk nonstop. I'm really interested if anybody would like to ask a question. Still no question, or the internet is dead and I'm just talking to myself. That's a possibility. Okay. No question, so we are going to go with the next case. 58-year-old gentleman has an ascending aorta dissection based on the CT scan, and the CT indicated a possible occlusion of the right common carotid artery and the subclavian artery. The past medical history, just hypertension. So the first, again, right common carotid artery cross section, and what you see here already that you do have some clot in the IJ, and I want you to watch really close. I will try to slow this down if I can. I don't know how to slow it down. So maybe I can slow it down here. I want to capture that right there. See, this is the tear, which is going to the carotid and also going to the subclavian. And that's the dissection that you see. That is definitely an intima flap going into the carotid artery. Let's play it. Oh, this is so much better. So at the beginning of the clip, you see those. That's the dissection that we see going to the carotid and going to the subclavian as well. So from the innominate artery. And after a nice grayscale, hopefully we'll get some color box. And a color box shows the flow. Hopefully that's the true lumen. The false lumen already clotted up, as you see it here. So that's already clot and no flow in that area. I want you to follow the subclavian, and hopefully we'll see some interesting picture in the subclavian in a moment. So the flap and the subclavian getting some flow. This is the clot in the right common carotid, and you see the flow is probably sneaking right there. And again, IJ is puffing some clots as well. And after some still images, hopefully we'll see some moving flap in a common here. You see the ICA going towards the head. I didn't see too much flow from the common coming up, but the ECA will be another big question. And the EC is also going towards the head. So I think this is one of those big interesting puzzles, that how this flow gets up to the bulb area when I really did not see too much flow in a common. I just want to go back a little bit and see that. So there was no color box put on the longitudinal view, but on the color box just present in the ICA and the ECA. I hope that we'll see the flap here, and here's a flow in a common, and again that's your dissection in the subclavian. And what you see on the subclavian is that you have two lumen, and here's your two lumen, the false and the true. The indication will be again what is your flow. This is a very small sample. I would increase my sample so I would be able to see both. So most likely this is your true lumen and this other flow is your false lumen. So this is maybe a true lumen because it's high resistance, is going towards the arm. Will be interesting to see that again the red, actually the blue is supposed to be going toward the arm because this is the origin of the subclavian and arm is going that way. So the blue, the negative flow would be my flow towards the arm in this case. Here's again the clot, and this is again because of an acute occlusion. You see the flow pattern, and you see the flow coming between those two pieces of clot. You see a little bit of flow coming up, extremely high resistance, but look at the velocity. So 384 and not much diastole. So that is the flow. It's coming through the common and able to give you that flow to the ECN and ICA. And with this dissection, or almost look like an acute occlusion proximal, you're still able to have some flow coming up and able to supply both ECA and ICA. So red going away and going towards the head, and again the red here for the ICA going towards the head. So again, the sequence of these measurements were not synced, but again, because it's unusual study and unusual finding, but at the end we have all the measurement done. One interesting, is this a other snowball, or is this a shower of emboli? Because it's sitting on a zero line, it's most likely a snoring, and you see it here, you see it here. Some other time when you see that noise or just coloring your box, this is the breathing coming from the patient. Again, your flow going towards the head, lymph node. Here's the vertebral. This is interesting. So snoring almost have a emboli artifact, but again, emboli would be randomly appearing. This is the same shape. That's why it's more based on the breathing and sitting on a zero line. Vertebral is antegrade towards the head. You see the clot again, and you see the clot in IJ. And one more image on IJ with a line in it. So let's see the left side. The left side, I have a open vessel with minimal disease. I do not see any dissection on the left side, so the intima is intact on my first assessment. So you can definitely appreciate when you see the intima and you want to differentiate the vein and arteries, that intima is just so nicely there. Thank God for this ultrasound. Otherwise it's hard to believe that one single layer of cells they can produce that beautiful signal. Just to know that this is my intima right there. Minimal disease in the bulb on the left side. And again, the left subclavian has a flap, and looks like that's a dissection in the subclavian on the left side. The two different color, two different lumen and flow direction. And again, red coming towards me, and this is where his one lumen is. Here's my other lumen. So this is interesting. Just if you look at the two different waveform. So this is most likely gonna go to the arm, and this is maybe stuck and in the false lumen. Let's go through the velocities for the left common, normal velocities throughout node stenosis, ECA with normal velocities, ICA with normal velocities, but interesting waveforms. So this is where the ascending dissection may definitely had some role of producing this little bit delayed artifact on the common already, but definitely it becomes more delayed when you go through the ICA. So here's your delayed upstroke for sure, and this is definitely an abnormal waveform. And this is where you really pronounce that systolic upstroke delay. Very good. Distal and the vertebral going towards the head. Uh-oh. Doesn't want to show me the subclavian. Sorry, that's another case. Well, ladies and gentlemen, this was my 4 cases for today. I would like to see any questions, or I don't see any questions. No questions, or do you see questions? No questions. Well, if there's no questions, I am going to hold up my last case, and what I'm going to promise that next month we're going to discuss a little bit more details of the abnormalities of the subclavian and the vertebral waveforms. We're going to keep interpreting interesting carotids And the second part of the year, I know how much you guys love venous disease. We are going to ask Dr. Noam to join us and give us some venous interpretation skills. Thank you so much for joining me today. And if you are watching the recording, please go to On Demand. You can see all our previous lectures on our YouTube channel, DeBakey CV Education. And on that YouTube channel, you can also have a link to our demand where we have our previous protocol lectures, the previous 3 annual meetings as well. Thank you so much for joining me. Have a great day and see you next month. Bye.